There's something more than just optimizing services. There's something more than just better ability to close the loop on referrals for social needs that's happening when you get organizations working together. Those are necessary, important kind of things. Of course, it's the heartbeat a lot of the work, but it's not the heart of it. What's really happening is that there's a life force, really. There's something else that happens that can actually translate into literally lives saved in a community.
Welcome to The Other 80. I'm Claudia Williams. At first glance, our work in The Other 80 is about bringing together medical and social care services. So, for example, layering housing on top of mental health or offering meals to people leaving the hospital. But if we want to address the underlying drivers of health, we need to go much deeper than new, individually focused services. How about increasing voting in poor areas? Setting up health outcome accountability at the regional level, or getting big tech to make products that help rather than harm health. Rishi Manchanda is the perfect person to deepen this conversation. He is the author of The Upstream Doctors, and he's CEO of HealthBegins. He joined me to talk about building capacity for health and thriving in America. So please welcome Rishi Manchanda to The Other 80. It's really wonderful to have you on today. And in preparation for this podcast, I suddenly realized I hadn't read your book. But that gives us a great chance to go back to 2013 when your book came out, which I think really put you on the map as an upstreamist. And would love to have you talk about what led to that moment. And also, what do you think has really shifted since that time?
Yeah, thank you. Those social needs, or social determinants of health, as they were called, weren't really getting a lot of airtime in the policy discourse, let alone on the ground in the practices that I was a part of. And I found this to be true, not just for myself, but for my friends and colleagues in other healthcare settings as well. And so in 2012, I started an organization along with some wonderful colleagues called HealthBegins, first and foremost, just to kind of provide a professional home for other folks who, like myself, were bearing witness to the downstream manifestations of upstream social arrangements that put people in harm's way. And then quickly, that network became a training network. As we were doing that, we recognized that there was this parallel work that was also necessary, which is to help integrate healthcare and social care together. And HealthBegins became a real place for implementers to share notes and best practices. And so when I got the opportunity to write a book, there was a journalist who at the time was working with TED, with the folks who put on TED conferences. And she reached out and she said, "Do you have one big idea that you want to write about?" No pressure. I said, "Okay, sure. Just one." And what I essentially told her was, the big idea. And by that point, I learned that talking about social determinants of health, it was difficult enough to kind of get my family at Thanksgiving to care about it, to really understand what I was talking about. And so I realized that if I wanted to help patients or colleagues kind of do this, I couldn't lead a conversation talking about the social determinants of health, which is a very jargony, wonky kind of thing to talk about. And what I learned from the people who inspired me in my career, even to go into this field of medicine, folks from the social justice movement, civil rights movements in the US and other movements abroad, the people who inspired me always taught us, I think, one thing, which is that real transformation requires not just data and strategic and tactical and financial kind of changes, but it also requires story. I came across the upstream parable and retold it in a way that allowed myself to include clinicians as part of that story, clinicians like myself. And I said, well, we are therefore upstreamists. And I told her that was the idea. I think we just need more upstreamists in the country. And she said, "What is an upstreamist?" And I said, "Well, if you give me a chance, I'll write a book about it." Yeah, it's been an incredible ride since then.
I was talking yesterday with people who help students create startups at Berkeley. And it can be a pretty predictable story. Somebody from the business school or engineering decides they want to start a company, goes to the Y Combinator site to find their partner. But what we were talking about is the accidental founders who have a social or personal issue that feels so captivating or so important that they have no other choice. And your story reminded me of that. I'm curious, as you first really were just trying to create a gathering place for these ideas, both in terms of the people and in terms of narrating that arc. What has it turned into that's different from what you started? You talked about training. Talk a little bit about Health Begins as it exists today. How has that whole idea, that accidental founder idea, evolved over time?
I really appreciate that, Claudia. The accidental founder might be my new tattoo or something. It certainly resonates because at that time, I had spent 4.5, 5 years looking for the home that I ended up creating, and for want of finding one. And so the accidental founder phenomenon definitely resonates with me as well. And I think Health Begins has gone through 2 chapters, and we're in the beginning of our third. So the first chapter was really, as I mentioned, in 2012 to about 2017, version 1.0. And that was the labor of love phase. Health Begins was a network that became a training organization. In 2017, Health Begins 2.0 started, and the accountable health communities model from CMS came along. And our friends at Mathematica knocked on the door and said, look, we've got this contract to help implement this new model to test out whether Medicare and Medicaid beneficiaries can benefit from social needs screening and referrals. And that project really was the tipping point to start to respond to a lot of inbound requests from Medicaid plans, from health plans with other lines of business, from large health systems, even large community-based organizations. And where we've landed, and what is now the beginning of the next phase of our work, or the third chapter for Health Begins 3.0, really is as a national mission-driven firm that helps Medicaid managed care plans, health systems, and community-based organizations to be able to meet the growing healthcare equity and social needs requirements, again, in the Medicaid space in particular, but to do so with a deep structural analysis to understand how to implement multi-level strategies to achieve not just compliance with requirements, but a long-term impact for communities harmed by societal practices. So, for example, with Kaiser Permanente, we were instrumental in creating the Health Housing Justice Initiative, which brought together the National Center for Medical Legal Partnerships with Kaiser to create medical legal partnerships across Kaiser's entire national footprint in order to improve outcomes for Kaiser members who are at risk of eviction, to stabilize their housing by virtue of connecting them to legal aid supports, and then to help unlock all the other kind of benefits of MLPs that we know can exist. So the next phase of our growth really is to use that positioning right now for Medicaid in particular, with plans, providers, and partners to really help apply our skills and to bring in even more consulting practices around areas like food security, around maternal health, around housing justice in particular, and allow our team to continue to really kind of drive the long-term impact we seek with communities. Our goal is to transform health equity with 250 communities by 2025, and we're more than halfway there already, based on the number of communities we've touched and the number of thousands of leaders we've worked with. Last year, we worked in 29 states with folks in there, and we see that work continuing for years to come.
I'm curious from your perspective as a system change agent, what do you think is unique about the California CalAIM initiative? How's it going so far? And if you could make one or two changes, what would those be?
Everything that's happening in California is remarkable. And there are 3 things that I'd kind of highlight to your point, Claudia. One is it's unique in terms of the scale, certainly, the scale of change, and the time frame for that change are the 2 major things that I think are remarkable. Those are also where the challenges come in, right? And of course, that has meant that all of the pain points have been a virtue of those 2 things, right? We're in the mix of a lot of change at the same time. So just a couple to kind of highlight that are really worth celebrating. One is, of course, the work to expand what's considered a benefit right now. So enhanced care management, community supports. These are 2 major initiatives under CalAIM, the Medicaid transformation work, that are notable here and have brought in now a lot of energy, a lot of engagement with folks who we know have always played a critical role with health, but have never formally been part of the healthcare delivery apparatus, and that's community-based organizations. Right. One of the things that we've already seen, of course, is how other states have been looking now to California to see that. So New York just got their new kind of waiver in place right now, and I think you can see some of the elements of that model that have clearly kind of taken some lessons from what California is doing. And so I think other states are going to continue to kind of look at the enhanced care management and community supports benefits in particular as a model. The other element that's worth calling out is the work that's happening around practice transformation. And so supporting now practices. I think in the first cohort, there are about 209 practices across the state that have now been selected to participate in statewide practice transformation efforts to have the building blocks in place to support this type of work. So the fact that the state is investing a lot of money into building the capacity of practices to get the building blocks in place to transform how they work for their patients and for, with partners in the community is a major big deal. So those are things that I think are notable. What would I like to see different or change? I will say two things that I've heard from others, and then I'll tell you what my own thing would be. I think others had said sometimes when they're in the throes of all this change, again, apropos of the time frame kind of comment, it's like, okay, can we slow down a little bit? That's one of the things that I know a lot of folks have voiced over. Sometimes the folks in the front lines are like, there's a lot that's happening here, and this is really challenging. And I think those are legitimate, valid concerns because sometimes the pieces don't always move together. And so my answer for the change would be, because of what I'm hearing from and what we hear from our the folks we work with, more convening spaces at the local level as well as at the state level for all of the system change agents that exist out there to come together and to share their kind of concerns and to be able to address them with support so that their concerns are taken seriously in a continuous improvement framework. There's the only way to get through this amount of transformation to achieve the goals that we want to seek are collaboratively. We cannot get through this individually as a hospital or as a health plan or whatnot. The more spaces for collaboration, the better.
Let's kind of build that out a little bit.
Sure.
Who would be the right organizing point for that kind of collaboration?
We've seen some good examples. I think it's a public-private kind of solution that makes most sense in this context, especially given what's happening in California. So the facilitated convenings that are happening around the state, these regional collaboratives, what's called this, again, another acronym coming, it's called CPI, the Collaborative Planning Initiative, I think. These CPI kind of collaboratives across the state were created about a year and a half ago by DHCS, by the state Medicaid agency, to help bring stakeholders to think about these. So to their credit, they did give the infrastructure and support to help bring folks together. I think I would build on those and accelerate and deepen those kind of collaborative models right now to move beyond just settings to bring people together and talk a little bit about process improvement opportunities, but to really kind of invest even more deeply now. And that investment need not come only from public Medicaid kind of agency dollars. It can also come in now from other places. So even local health department funding, public health funding can come in here. And then to the private part, this is where private philanthropies, philanthropic foundations, community benefit departments, others, there's ways for us to kind of pool resources into local collaborative models. So the collaborative nature of these things is what's going to unlock not just the capacity of Medicaid transformation to achieve its goals, but also it's the same kind of model we need for public health work. We spend too much time, I think, recreating the same tables or creating new tables, right? And sometimes creating no tables at all for people to come together in different communities. What I'd like to see is public-private kind of solutions to build on what we already have and enabled by the Medicaid work here to go deeper and to solidify the infrastructure for regional collaboratives. And we can learn from examples of in Oregon, for example, the CCOs and the other kind of regional governance mechanisms. There are other states that have actually been experimenting with these types of models as well, of formalizing now local governance and local collaboration in a way that goes beyond just a set of facilitated meetings, which is what's happening right now. So I think there's a lot of great progress that's been made, don't get me wrong. And I think there's a lot more that we can do to really help to move us towards more regional governance and accountability mechanisms for collaboration and problem solving.
You've mentioned Oregon CCOs and also the New York waiver. Oregon and New York created regional hubs, like a middleware interface. In other words, that would bring together the community organizations, help them contract effectively with the other folks, maybe even do negotiations. Whereas in California, lots of focus on the health plans as the conveners of those CBO networks. I'd love to hear your point of view around those two models and what seems to be working either in both of them, or which is your recommended path.
Yeah, I think it's a both and kind of solution that's required in California, frankly. It's problematic to have all of the convening and governance kind of functions of a regional planning body be something that rests with a health plan. That's beyond the gambit of any health plan to kind of do. There's something important about a regional governance kind of model and mechanism that is not just serving technical assistance capacity and helping to facilitate some of the data sharing and the financial payment adjudication. Like those are key functions, right? But there's also additional features that are important, including governance and accountability. There's a lot of healthcare delivery that has never been really anchored to place-based planning. What are the needs of that place? What are the health problems in that place? And how do we organize resources effectively to be able to address those needs? And we've seen experiments in the US to that point. So Maryland had a great example, right? Global payment models. We've seen some rural examples in Pennsylvania and other places. Like there's all sorts of interesting kind of experiments that are trying to, in some ways, get to not just how to improve value, but how to organize outcomes and value by place, right? And that's a very different kind of model than a model where, for a health plan or healthcare system, where board members may not necessarily represent right, the community, right? Our governance mechanisms in these institutions just haven't, for the most part, there are some notable exceptions, but for the most part, in California and other places, hasn't been set up to be accountable to community members.
And it kind of led to another question related to a recent Medi-Cal announcement, which is requiring plans to work with counties and as I understand it, hospitals on community health improvement plans. And my first thought when I heard that, to be a little cynical, was, oh my gosh, haven't we tried this before? Hospitals and hospital systems have always had to create plans to as part of their nonprofit status, but it's rare that those actually are tied to action. They're almost always bringing together all the survey results for that community and pretty charts showing that diabetes is a problem, right? Which we knew when we began. So I'm curious, for a community, designing what that effort would look like, this new community planning effort. What would you do? How would you actually go about making that meaningful?
It's a great question. I don't know if you could see the grin ear to ear that I was when you talked about the cynical, but I think realistic perspective on this. The amount of dollars that go into community health plans relative to all the other kind of investments right now that health systems make is pretty anemic. Plenty of folks like the Lown Institute and others have done a remarkable job in kind of naming some of these challenges. And as much as, of course, I understand the concerns of those in health systems and the critiques they have, some of them are valid kind of methodological critiques about some of these assessments that are coming out. The underlying kind of premise is absolutely true, which is that we have not developed a healthcare system in the US right now that is truly accountable to improving local health outcomes. Full stop. That's a problem. And so if we want to name that and then address that, then I think three things can be true at the same time. One, the new all plan letter, the new kind of guidance to the plans to encourage them to now work with counties and healthcare to coordinate around the chips, I think is a step in the right direction. Is it necessary? Yes. Is it sufficient? Absolutely not. Right. And so I think the second thing that I think is also true is that the ability now to tie incentives, financial kind of payments to this is a critical next step. And this is where the community reinvestment requirements right now for plans, the Medicaid plans in particular, right, 5 to 7.5% is going to be really interesting. One of the most interesting kind of aspects of that is that community reinvestment requirement and the dollars that flow from that attached in any way to the community health improvement kind of plans. I think this third element has to be the nut to crack, which is how to create more local and state level accountability, and to make sure that the accountability and the governance mechanisms at a regional level now take into account the data at a community level, ingest the data from the health plans and the health systems, right, as well, which is where HIEs now play a major kind of role. How can HIEs and social HIEs and CIEs, right, how can these elements of infrastructure be part of the accountability mechanism at a local level to see how folks are using data, understand the inequities that we're seeing in our communities, and then making sure that they're holding the plans, providers, health departments as well, kind of accountable to addressing those in that way. That's the infrastructure that's still missing, and that I call that equity infrastructure. And in some states we see more equity infrastructure, in some states we see a little less. I think in California we have some opportunities to really build that out.
I remember when I was at ONC, we had this White House convened working group where Anish Chopra and Farzad Mostashari would convene all of the federal leaders around health IT, and ONC's job was to try to create more alignment across all the federal leaders. And somebody privately came to me because I was helping launch this and lead it and said, "We don't think you have any authority We'll come to the meeting, but nothing's going to happen here. And so that's part of the challenge of these things is how do you create enough of it? To your point, is it the finances? Is it some kind of hoop you have to run through? Can it happen just organically because communities care so much? I don't know what the right answer is there.
Well, I think you put more succinctly what I was trying to get to a little while ago, which is that what I'd like to see, the change I recommended for that I'd like to see most with Calium right now is more of that collaborative network kind of model. But in a way that's more robust than what we have right now. It's really, there's a lot of coordinating without a lot of the authority to kind of ensure that that coordination is going to be tied to money,
Something,
to
yeah.
outcomes, and to impact. And I think that's the next step. And that's, of course, the most politically fraught one. It takes decisions in that kind of way, but it certainly can't be only at the state level. And I think the folks who are leading this actually recognize that as well, which is to their credit. They're implementing a lot of changes and they're trying to put in place some policy levers to make sure that there's now more coordination happening. And I think that this is hopefully in the direction of then creating more of that coordination with authority, right? That local accountability. And that is a necessary kind of counterweight to the authority that lives at the state or the plan level. Local community-based organizing is necessary. And we've seen this before in other initiatives. Like there's remarkable examples in U.S. policy where we've seen efforts to increase accountability just as we're rolling out new initiatives. There's I think it was the Community Development Block Grant model many years ago. There was funding that was set aside at the federal level for participatory citizen monitoring efforts of block grants that were rolled out to actually support citizen oversight, right? Local capacity to actually have oversight to help make sure that a federal policy, a federal implementation was actually working in ways. So there's ways to build capacity for local governance and local oversight and state level kind of oversight as well, while we drive improved implementation, right? Implementation sometimes sacrifices accountability or local kind of governance kind of mechanisms at the altar of we just got to get people served. And I think that we don't have to kind of fall into that trap. I think we can recognize there's ways to kind of get the dollars out the door, get the services out the door, get the access that we need while actually, by building out the local capacity and the local governance. And I think that's what I see as a really interesting opportunity for us in California.
One of the things we've already touched on very deeply is this idea of capacity building. And there were 3 specific angles on that I found in your writing and other podcasts that I found really interesting. Because typically when we think of infrastructure and capacity, we think of either data and computer systems, or we think of like service delivery infrastructure. And these are very different slices on that. So the 3 are relationship networks, civic engagement, and business models. And we'll dive into each of those. We started to touch on the relationships piece. You had a quote, and I don't know if you were pulling this from somewhere else, but I found it fascinating, which is density of relationships among population health organizations in a community correlates with lower mortality. And you call that community social capital. Talk more about that.
Yeah, so this is, I was referencing in that piece something that was put together by some researchers about, no, I think it's 8 years ago now. I believe it was in Health Affairs where they published this. And the researchers described the term, I believe, was comprehensive system capital. At the individual level, we know the importance of social connection and relationships and social capital, right, as a way to help improve our individual health. Well, what's the analog for community, for institutions in a community, right? And I think the comprehensive system capital description, which we kind of in a shorthanded kind of way said is, to shorten it, said community social capital, gets to, and the kind of correlation they found in this study from several years ago found that what we see as a benefit for social connection for individual networks, for individual connection to as an antidote to loneliness and to improve outcomes, well-being, et cetera, is also true for communities, especially when as we look at the relationships between the institutions in a community, population health organizations, as the researchers were calling it. And one measure of that is density of relationship. How often are they working with each other versus separately? And as these researchers found, the denser the relationships between those organizations at a county level, according to research now done many years ago, was correlated with lower mortality. So obviously correlation, not causation necessarily in this study, but still I think a really intriguing kind of notion here that certainly resonates with a lot of experience, that I and many of us have kind of had in this space, especially those of us who work with these multi-sector collaboratives or regional hubs or whatever we're calling them, particular settings. And that's this notion that there's something more than just optimizing services, right? That happens when organizations work together. There's something more than just better ability to close the loop on referrals for social needs that's happening when you get organizations working together. Those are necessary, important kind of things. Of course, that's the heartbeat a lot of the work, but it's not the heart of it, right? These are just the beats but what's really happening is that there's a life force, really. There's something else that happens that can actually translate into literally lives saved in a community. And it's not just by improved services. It resonates with me because, I have done a lot of work in thinking about social needs and social determinants. And in the US, what's notable is that most of the discussion to date is still, when we talk about social needs, still comes from what scholars would call the basic needs approach for human development. Basic needs meaning, do you have the commodity in place that you need to be able to live your life and to be healthy? Do you have food? Do you have housing? Yes? No? Right? Do you have the basic need or do you not? There's an alternate kind of model that, going back almost 60 years, has been in place in international development, human development kind of circles. And that's not looking just at the presence or absence of basic needs as a commodity kind of view of having something in place. It's actually looking at opportunities. So Amartya Sen, famous economist, Nobel Prize winning economist, has written about this. Development as Freedom was one of the preeminent work by him and John Drez. They're characterizing what FDR talked about many years ago in the US, which is this idea of freedoms, right? Being defined not just as a presence or absence of basic needs, but as opportunities. Do we have things we need to pursue the opportunity for a dignified, full, fully realized kind of life? And of course, are those opportunities equally spread? The reason I share that kind of walking out on basic needs versus kind of the freedoms kind of perspective is because when we come back to this question of the density of relationships between organizations, part of what might be happening over here, right, is this not just about increasing access to basic needs that we're unlocking when organizations work together, but it's also that these organizations are finding new ways to create more pathways to freedom of opportunity for residents in a community. What you're hopefully doing is unlocking freedoms of opportunity for people whose freedoms have been denied or suppressed or delayed because of structural violence. That's what's intriguing for me about the density of relationships between institutions and not just the density of relationships between individuals. It's comprehensive system capital, as they called it, or community social capital, as we call it, be something that we take into account from policy making to health plan payment kind of models, value-based payment models. It's not just an interesting intellectual kind of exercise. It's also something that has, for me, profound implications for policy and for implementation as we think about building systems out there. Because, for example, if you're a community, say in San Diego, and you've got a lot of wonderful folks coming together around community supports in California, around CalAIM. I was just in a room with folks in Orange County actually during this week. We were talking with folks at CalOptima. They brought together 120 community providers that they worked with over the past few years to provide social services and through community support. It's a really beautiful group. And what I remarked to the group was that this group for me represented something more than just the ability to access housing and food and transportation. It was the ability to kind of unlock comprehensive system capital, community social capital, because that's, according to some of the research, potentially life-saving, because it's unlocking opportunities now. It's a civic kind of muscles, and that's the second kind of area that we can segue into, but it's unlocking kind of the ability for a community to kind of really be a thriving space, a place to provide not just basic needs and vital conditions for living, but opportunities and freedoms. And a lot of our health outcomes really are tied to the experience of opportunities and freedoms and not just the presence or absence of food.
This is reminding me of the conversation I had on this podcast with Tony Aiton. I asked, well, what did you learn from the $2 billion invested in community health in California? And he said, it's about power, voice, and creating more democracy at the local level. And one of the pieces that you've really focused on, and you had an initiative, I think, that preceded HealthBegins called RX Democracy, is what you call the Medicaid voting gap, and really trying to activate more voice among Medicaid, Medi-Cal enrollees. Can you talk about the opportunity you see? We're coming into an election season very soon. What is the gap you see? What is the opportunity you see? And where are some places that's really being manifested?
Yeah. Well, Tony was certainly right? That in that lesson learned, it really is about power and resources. And I would say resources for exercising the freedoms that we all want to see. And it's a really interesting kind of conversation to have when we're in healthcare kind of circles and institutions. When you talk to somebody in a healthcare system who's talking about building and coding for social needs, or how to look at data collection for race, ethnicity, and data, and stratification and the technical. We can get technical really quickly, and necessarily, I think it's important to talk about technology, but sometimes the technology and the challenge operationally becomes the thing rather than to what end. Why are we doing this? And it's really about actually reallocating resources and power to be able to correct for things that have put people in harm's way. Simple as that. So I think Tony's analysis is spot on. And from a perspective that says, well, it's lack of power and its ways in which power has been exercised or deprived, right, from populations, that is a major driver of health. Daniel Dawes has spoken about this, of course, the political determinants of health. Jack Geiger spoke about political determinants of health even prior to that. There's others who've been talking about this for a long time from that perspective. And for those folks, it's not that surprising to say, well, from that analysis, political enfranchisement, the ability to vote, the ability to engage civically in your life, and to have that engagement influence policy is a driver of health. And therefore, we should look at institutions in society, including but not limited to healthcare institutions, who, again, ostensibly are there to promote health, right, as opportunities to get people connected to that, to exercise that right. And so in 2008, I was, just like all of us, kind of really deeply activated by what was happening in the political scene. There's a major election, of course, we can all remember at that time. But in general, we all know that civic engagement is kind of key for us as physician advocates. But it's also, of course, key for those we serve, especially those most marginalized. And I said, as I've kind of read about this, the 1993 Motor Voter Law, otherwise known as the National Voter Registration Act, which effectively made it the law for places like the DMV to make voter registration accessible. I said, up until 93, there was nothing more intrinsically democratic about the DMV than a doctor's office. The founders didn't sit there, many years ago and say, the way we're going to make sure that everybody has the ability to have the right to vote in America is through the DMV. They couldn't have foreseen that, but what the law did appropriately was to say, well, we want to improve access.
The buggy place, right?
Yeah, exactly. And so I said, the very fact that the DMV of all places is a place that's now associated with the access to the right to vote, to register at least to vote, and then figure out ways to unlock the ability to actually vote. The very fact that the DMV of all places is a place that's now, it's so commonplace as to be I said, there's nothing more democratic about the DMV than, say, the doctor's office, especially when we consider under that law, the 1993 law, that by Section 7 of that law, any agency that receives federal funding, by my interpretation, that includes Medicare and Medicaid, any agency that receives federal funding is required to provide access to voter registration, nonpartisan voter registration. That law has been in place since 93 and very, very rarely has been enforced, particularly in the healthcare space, to ensure that those of us who receive Medicare or Medicaid funding in the healthcare systems are actually living by that law. And what I said in 2008 was, well, maybe we just point out that this is the law, and that we should rock the vote and our equivalent, RX the vote. Let's RX democracy. Let's kind of do this. And so we registered 30,000 voters in doctors' offices and clinics. This coalition, especially led by our friends at the National Association of Community Health Centers, it led to a lot of discussions with folks in the civic engagement community and voter education community who have long not really looked at healthcare as a vehicle for engagement. And I'm proud to say that the campaign is still alive right now. So the Civic Health Alliance and organizations like Civic Health Alliance and Vote ER and others have now really continued to kind of carry this torch in wonderful ways to expand this notion of what voter engagement can look like in healthcare. Because we know that while issues like housing and food and transportation are certainly social determinants or social drivers of health equity, political enfranchisement and voting and civic engagement are as well. And so the Medicaid voting gap, just like the Medicaid SNAP or Medicaid WIC gap, really represent kind of gaps that exist right now, where there are some people who are eligible for one service who are also eligible for another, but aren't necessarily getting enrolled at the other. Much like we were seeing with SNAP and WIC, we think there's an opportunity for those who pay for Medicaid, those who adjudicate payments for Medicaid plans, as well as those who provide services to Medicaid beneficiaries, meaning health systems. We think that there's a role for them to play to make it easy to get access nonpartisan voter registration and to promote kind of polling. So I want to see a future where a polling location is at a local hospital, not just a local school, or nonpartisan voter registration activities are taking place in a clinic of a local community health center or a doctor's office or a hospital, not just at the local post office. That's the future that we need to see right now. And that requires us to shift the dominant model of what we view as healthcare, which is some sort of professionalized, highly specialized, remote kind of activity, and really view it as something that's central to the pursuit of health and equity in our country. And again, as Tony rightly said, it's all about power. If we understand that, then it's not surprising at all to consider that we have the power to be able to help other people achieve theirs.
At the end of the podcast for the last few months since I joined the Berkeley School of Public Health, I've been asking guests for their thoughts, insights, suggestions for how might the Berkeley School of Public Health and schools of public health in general be a part of the change and movements that you're describing and really help drive them. What would that look like? What would be some example projects or initiatives you would love to see come out of a school of public health?
Well, I think apropos of the conversation we were just having, I think there's opportunities here for public health schools, including Berkeley, to center conversations about power and political kind of enfranchisement as a political determinant of health, like exploring political determinants of health, and then allowing public health students and practitioners to be able to understand the political determinants of health and then understand their role in being able to help to address them and improve them, I think is a major kind of opportunity. There's a second one as well, which might sound to some ears weird for me to say, having just talked about political power, and that's finance. So more and more these days, we find folks we work with, particularly who come from public health backgrounds, who are now in positions of authority and influence in healthcare, challenged by making the business case, how to calculate the ROI, for example, for equity interventions, including interventions to address social needs. What we've done to address that is to help folks understand how to not just in a narrative way, but also in a really concrete way, calculate returns, value, and the social impact of investments. So it's ROI, VOI, and SROI. In order to, as a necessary element of understanding how to make the case for the work, and then how to track the impact of investments that we make in these spaces. That type of thinking about what it means to social impact investment, calculating returns, value, and impact, translating those into monetary value, right? That impact into monetary value where necessary, and learning how to translate that into a business case are absolutely essential skills, right, for public health practitioners to be able to engage, not just in local health departments, but I think as many do in other settings as well, including healthcare. So finance, thinking about how to to quantify and then communicate the returns, value, and impact of health interventions, I think is a powerful opportunity for Berkeley and other schools of public health to be able to advance, as well as, of course, addressing the political determinants of health.
So appreciate your coming on. You were eloquent, interesting, and maybe you have to go take a nap now, but I really appreciate your coming on, even though you felt really jet lagged.
Thank you. I appreciate, obviously, deeply the opportunity. I'm, like I said, a big fan. And Claudia, it would be a dream for me to kind of chat more with you about ways to collaborate. So
thanks, Rishi. Appreciate it.
Take care.
Have a good one.
You too.
If there's a state we talk about the most on this podcast, it's got to be California. And it's not just because I live here. It's because California is tying together several policies to unleash the kind of local, place-based health change we need in this country. Need proof? Well, first, California has a network of regional and community-governed Medicaid plans. The state is implementing one of the most ambitious whole-person care efforts in the country. And starting in 2024, Medicaid plans and local health departments will need to work together on community health assessments. And finally, beginning in 2024, Medicaid health plans must devote 5 to 7.5% of their profits to their local communities. It's the kind of ambitious, place-based, and system-level change we need in America. This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Kloss. Check out the show notes for more information on Rishi Manchanda and his work. There is more information on my background, this podcast, and our guests on our website, www.theother80.com. Until next time, I'm Claudia Williams.